We have another eminent speaker tonight, Dr. Zainab Habibullah. Dr. Zainab is a consultant in nephrology and transplant nephrology. She is the head of organ transplant center at King Abdullah Medical City. And Dr. Zainab is gonna talk about CRRT versus intermittent hemodialysis in acute kidney injury, when and what modality. So please, Dr. Zainab, go ahead.
Thank you for the invitation for the presentation. Second, it's usually a challenge to be the last one to speak, but after such an incredible حقيقة talk, I enjoyed Dr. Adil, your talk. Actually, it was very useful. Thank you for everyone. So inshallah, my talk will be short and quick one. I'm gonna go to discuss what's the CRT modality is, what's the dialysis renal replacement modality is, which modality is the best, and when we should start the RRT. So we will go quickly over some definition, when we initiate the dialysis, as I said, the modality of the RRT, and some of the CODICO guideline 2012 for the initiation of the dialysis. So based on the topic, so we will go with when and which dialysis modality is. I will start simply with some definition. So what's an acute kidney injury? It's already covered well by the previous presentation. I'm just gonna go quickly. So according to the CODICO guideline, AKI, it's either increase in the serum creatinine of 48 hours, increasing in the serum creatinine 5-fold from the baseline, and this basically to the people with CKD for for 7 days, within 7 days, or decreasing in the urine volume, which is less than 0.5 ml per kg per hours for continuous 6 hours. So to say that patient is have an AKI. Another definition is what the dialysis is basically a process where the solute composition will be moved from one side, which is the blood, or basically blood through the permeable membrane to the other side. So here the modality of the RT, which we have based on the mechanism, which is either diffusion or convection. So we have an intermittent hemodialysis, the usual one, which is, I will explain later what's the difference between each and everyone. The other one is the continuous renal replacement therapy, or CRT, with all kind of modalities. Have either hemofiltration, hemodiafiltration, or hemodialysis, or SCUF mode. And then the last one, which is a prolonged intermittent hemodialysis, or SLED. So other name is sustained low efficacy daily dialysis. So my entire topic will be to differentiate what type of the dialysis should be used basically between these three. What's the difference is, as we know, IHD is basically, the main difference is its duration. So it's intermittent hemodialysis is 3 to 4 hours dialysis per day. It's used in intermittent solute removal only by diffusion. We can use it ultrafiltration mechanism or convection, but the main action or mechanism of action will be the diffusion. It's used a high dialysation flow and the blood flow, so that's why it's usually not used in hemodynamically unstable patient. One of the main side effect of the IHD is the hemodynamic unstable episode, the hypotension episode, and it's basically used in used anticoagulation. It doesn't require to use anticoagulation, so that's one of the most important benefit of the IHD. The other form of dialysis, as we said, is a continuous renal replacement therapy. Its duration is 4 to 24 hours per day. It's a continuous removal of the small to middle molecule. It's used basically convection or again ultrafiltration. blood flow is only 200, so that's the reason why we use it in the hemodynamically unstable patient. The main complication is the um, is usually, I will say, the hypothermia. SLED is prolonged intermittent hemodialysis, which used to use to go with the slow, sustained, low efficacy daily dialysis in the small to middle molecules. It uses the same machine as IHD. It doesn't require a specific machine, but the hours of dialysis is from 6 to 12 hours per day. And dialysate flow, it's basically between the CRT and the IHD, and it's the same as the blood flow. So it could be used in hemodynamically unstable patient. The main side effect and complication of the SLED is the air embolism, because it's basically used for prolonged duration. And again, the hypothermia. So we'll go quickly with the indication of the dialysis. And when we start the dialysis for the patient, we go with the basically if there is a refractory fluid overload, refractory hyperkalemia, any sign or symptom of suggestive uremic patients such as pericarditis, encephalitis, or severe metabolic acidosis, or some of the medication or alcohol intoxication which need to be removed. So when we started, there is usual a controversy between nephrologists who start early versus late dialysis. So there is a lot of study which actually called the early. I'm not sure where did you guys reach to. So this is the new, as I said, I'm going to present the last two study about the initiation of the dialysis. So this one is published in July, basically 2020. So it's an randomized controlled trial involving the critical care patient who has a severe acute kidney injury according to the CODICO guideline. Patient was randomized to either an early start of the therapy, which is, as we said, it's within 24 hours, 12 hours of randomization. And the other category was a standard strategy where a patient is requiring have an indication for the dialysis to start and renal replacement therapy, looking for the primary outcome with death from the for any cause within 90 days. So this is the characteristic of the patient which being collected. They exclude all patient who has an emergency indicated from the beginning, any patient who have a previous renal replacement therapy or advanced chronic kidney disease, and uncommon cause of acute kidney injury. Looking in the primary outcome was the cause of any death within 90 days. So it's basically either the accelerated, which is the late start, or the standard, sorry, the early start, or the standard, which is the late start. There is no much difference being seen in the death within 90 days. They have also in the study looking for the secondary outcome. There is about 39 secondary outcome actually, but the main I will mention here the basically the stay on the hospital, one of the important I think outcome that as it says, there is no much different between the stay in the hospital between our early and late start. Also, the use of the ventilated between the two group, there is no much difference. So in conclusion, among all critical care patients with acute kidney injury, the early or the late start of RRT has show no difference, and with no change in the risk of death within 90 days. The other study, which published in Lancet also in 2020, looking for, again, it's a systemic review for all trial with the published from April 2008 till December 2019, that compared a delay versus an early start of RRT in the patient with a severe acute kidney injury. Trial was eligible for including and all patients who's 18 years old and have an acute kidney injury. And the primary outcome was all-cause, again, mortality within 28 days of initiation of therapy. So the total number, so there is 9 study was included in this systemic review. The number of patients was 946 for the delay start and 933 for the early start. There was no much difference between the patient category, and in the outcome, they basically looking for, this is the 9 study which included, so the difference between the delay and the early start within the 28 days, it's basically showed no significant difference. Also, as I said, in the 28, this is representing the 28 days mortality, is 44 here, 43. The length of the hospital stay, it's almost the same. And basically, there was no much difference between the two early or versus late. In conclusion, the timing of the RRT initiation does not affect any survival in the critical care patient with acute kidney injury, and delaying in the RRT initiation with the close patient monitoring might lead to reduce the risk of the RRT. So which modality we should use? Either we will start with how we choose the type of the modality is basically depend on first patient, if the hemodynamic stable or unstable patient, as is mentioned before, the time frame for how long we want the patient to be on dialysis. Is it a patient going for procedure? Is a patient is going to be stable to be shifted from critical care? So time frame is make a difference. What type of fluid or solute we need to remove? Is it a small solute or medium molecule or large molecule? Is it a protein bind? Is it or the fluid type of removal? And then, of course, the cost effective for each type of modality, and if there is an anticoagulation need. Also, one of the very important difference and the choose of the modality is the survival benefit. So here they are looking for, in the one of the systemic review, they are looking for the difference in the ICU mortality between the CRT and the IHD. Again, it's almost show no difference between both modality. The most important part for the nephrologist, of course, is the recovery of the kidney function. Is there a difference between the CRT and IHD? It's actually showing that the patient who is in the CRT have it could be dialysis dependent at the time of the discharge. However, maybe the largest number was in the MEHTA study, but it's have actually, if you review the entire study, it's have a lot of downside that the selection of the patient in the CRT wasn't appropriate. It was more sick patient. Even though it's represent that CRT have a higher risk of the patient who may end on dialysis, still there is no strong data suggest that. Sorry. So the other modality, so IHD, intermittent hemodialysis, or CRT. So we go with the effect of continuous continuous CRT versus replacement outcome, the critical ill patient with in the acute kidney injury. This is a prospective randomized controlled trials. It's a single center randomized controlled trials, which including 252 critical ill patients in Germany, randomly assigned to either CVVH or IHD with the prescription of 35 ml per kg, which is the usual dose we use in the CRT. So 128 patients in the IHD for hand, and CVVH is 122. There is only, this is the number of the patient who has a crossover, which is shifted from one modality to the other. Survival of the patient is almost again the same, maybe a little bit higher in the CVVH. Mortality is almost the same, and there is no difference and also creatinine at the time of the discharge. Another study, which is again comparing a randomized controlled trial of the CRT again versus IHD. It's a multi-center randomized controlled trials conducting a dialysis, comparing a dialysis modality of IHD versus CRT for the treatment of acute kidney injury. And the principal outcome, again, the main principles, usually the mortality and the length of the stay and recovery of the kidney function. In all two form, CRT or IHD, there is no much different in the recovery, in the renal recovery, in the mortality, or in the length of the stay. So another meta-analysis study, which is comparing again IHD with CRT, is again showing no much difference between the two modalities. I think Dr. Adil already mentioned the Picard study for the volume management. Here, it's give the bigger hand to the CRT for the fluid management and instead of the IHD only. So in conclusion, when we use the CRT or IHD, CRTs may be associated with the advantage of hemodynamic stability. Basically, hemodynamic stability is thought to be related to the slower solute and volume of course removal, permitting a superior management in the volume overload patient. It's used basically in clearance of the inflammatory mediated, especially in the septic shock patient, which may provide the benefit in the, as I said, septic shock patient. And it's also a benefit of using CRT in specific to the patient who have cerebral edema, acute brain injury, or fulminant hepatic failures. The other modality is the difference between CRT and the prolonged intermittent renal replacement therapy, which is the SLED. There is no much, actually SLED, it's maybe not used in a lot of center. However, now in the COVID time area, there is a good new study, which is, a lot of centers start to use this SLED because of inavailability of the CRT and some cost-effective issue. But however, study-wise, basically sustained low, the SLED is have only a couple of studies. This is one of the study was published in 2012, looking for the difference between the SLED and CRT. So it's this characteristic of the all patient, which almost have no difference. And we're looking for the survival benefit within 90 days between the SLED and CVVH. Here, the SLED have a better hand, but the difference between both was not significant statistically. The 30 days mortality and 33 days renal replacement dependence is almost also no difference between the SLED and CRT, very minimal difference with the better in the SLED arm, and also in the early clinical deterioration. This study which showed the main maybe outcome was an important outcome I mentioned is the nursing time spent between the SLED and the CVVH. So SLED have a lower time, of course, with the nurse than the CVVH time, which make a cost difference between both modality. So in conclusion, when we are comparing SLED with CVVH, SLED was associated with reduced nursing time only and lower cost, but however, in the patient outcome, there is no difference. What's the benefit of prolonged intermittent dialysis or SLED? It's early mobilization to the patient. And if the patient is going for any procedure, they can do that easily, less anxiety to the patient himself. And as we said, it's a cost effective. This is basically the difference between the SLED and CRT. So as we mentioned before, hemodynamic stability is more in the CRT than in SLED. The higher cause of the CRT than SLED. The anticoagulation use is more in SLED than CRT. And then the risk of bleeding different with higher with CRT. So comparing all three modality of dialysis, which one is what the advantage and disadvantage? So if we go with IHD, we basically use it for hemodynamically stable patients, CRT and SLED for unstable. the advantage of IHD, the main advantage I will consider is we can use the intermittent hemodialysis without anticoagulation, and the cost effective, and is of course the quick and rapid removal of the toxic. However, the CRT advantage is basically, as we said before, the volume part, that it's a better control of the volume, especially with hemodynamically unstable patient. And the advantage of the SLED is, again, it's using it in the hemodynamic stable patient with less cost. The disadvantage of the intermittent hemodialysis is the hypotension. And in the CRT, I'll consider the hypothermia, maybe according to our experience, hypothermia is more than anything else, and the immobilization of the patient. And SLED, the highest number, the main disadvantage is it's a complexity of use and high risk of air embolism in SLED. So I'll move to KDIGO guideline for basically about the use of the RRT in AKI. So they basically, again, the first part of the guideline that to initiate a dialysis only when there is an indication, either electrolyte, acid balance, or exist. And they suggest using a CRT rather than the standard intermittent hemodynamic, other than intermittent hemodialysis for hemodynamically unstable patient, using a CRT rather than the intermittent for AKI patient with a brain injury, and the KT/V, which is recommended for the dialysis, is to reach 3.9, and the dose of the CRT is 20 to 25 ml per kg. In the KDIGO guideline and the Canadian Society of Nephrology work group, they agreed that in the absence of the evidence which show any survival benefit of any modality over the other, the continue intermittent or CRT, we use the modality which is suitable to our patient, the dynamic state of the patient, and then of course, according to the local availability and the cost effect of modality. So in summary, which again, I will answer the two questions. When to start, there is no difference, as we said, if early or late start of the dialysis. However, if preferable to use the late start of hemodialysis to prevent an increased number of dialysis or using an unnecessary dialysis session. And which modality to be used is, again, there is no difference. It depends on the center, depend on the course, and depend on the patient and the availability of the machine itself. So that the main two questions was from the lectures. Hopefully it's I reached to the point which needed. Anyone have?
Thank you, Dr. Zainab. Yeah, of course, it was targeted to the points, very brief, simplified, and informative as well. Thank you very much for the nice presentation. And I think we came to the end of this brilliant webinar. I would like to thank Dr. Saad. I would like to thank our attendees today for their patience to stay till the end with us. I would like to thank the chairman of the day, Dr. Adel Hussein, and our eminent speakers tonight, Dr. Ahmed Madi, Dr. Zainab Habibullah, and Dr. Shams Abdurrahim. Thank you very much for your attendance. Thank you all panelists and attendees. And we hope to see you on the next webinar, hopefully about acute kidney injury.